Hello, my name is Meg Monday, and I'm the Director of Educational Programming on Cancer Connect. I want to thank you for joining us today for a live chat with Dr. Neal Shore. In today's web chat, Dr. Shore will be discussing managing side effects and maximizing health during and after prostate cancer treatment. Dr. Shore is the Medical Director of the Carolina Urologic Research Center in Myrtle Beach, South Carolina, and the Managing Partner for Atlantic Urology Clinics, where he participates in a full-time clinical practice. Dr. Shore has conducted more than 150 clinical trials, focusing mainly on prostate and bladder disease. We are very excited to have Dr. Shore as today's expert. Thank you for joining us today, and I will now turn the presentation over to Dr. Shore.
Good evening, everyone, and belated happy Thanksgiving. It's a privilege for me to address the listening audience, many of you who may have prostate cancer or other cancers, and many of you who are family members and caregivers. Tonight, we're going to talk about strategies to manage the side effects and maximize our health during and after prostate cancer treatment, which is really so important. Obviously, we want to cure cancer, we want to cure prostate cancer, but we also want to maintain our quality of life. So I'm privileged to have that discussion with you tonight. Before we go forward, let's talk about the prostate. What is the prostate? And as you can see in this diagram, the prostate's sort of right in the center of the diagram here, just between the bladder and the penis. And it's a walnut-sized gland, and its real function is to contribute fluid to ejaculation. Most of the fluid in ejaculation actually comes from the prostate and these little tubes behind it called the seminal vesicles. Only about 5% of ejaculatory fluid is actually sperm, which explains why when men have vasectomies, they really don't see much of a difference in the actual volume of fluid. But the prostate is there to help conduct the flow of sperm, so we sometimes call it an accessory fertility organ. And as you can see, it's at the base of the bladder, and it has ducts which go into the urethra as part of the urethra, which is the tube which travels within the penis, through the prostate, and into the bladder. So the role of the prostate is really just simply that, to contribute this fluid for fertility purposes. Couple of things happen to the prostate as we get older. It just enlarges in most men, and it probably enlarges secondary to some changes in the ratio of our hormones. All men, just like all women, have testosterone or male hormone, and all women, just like all men, have female hormone and metabolites of that known as estrogen. And so there is some theory that there's a change in the ratio of testosterone and estrogen levels. Some of the enlargement of the prostate we see may be based upon that, and some of it could be based upon genetics. We're not really completely sure. And the other thing that happens besides the prostate enlarging, which can cause some worsening urinary symptoms to men, enlargement of the prostate, we call that BPH, or benign prostatic hypertrophy. The correct medical term is hyperplasia, but I don't want to really get too into the weeds on that nomenclature. But the second thing that happens, other than the prostate getting bigger on us and blocking the flow of urine, is it can lead towards a change in cells, which can lead to cancer. And every year in the United States, we diagnose about, almost 250,000 men with prostate cancer, which is quite a large number. Now, many of the men don't need to be treated and can be managed with just monitoring, or what we used to call watchful waiting, or now we better describe it as active surveillance. But unfortunately, many of these men may go on to develop a disease or a cancer of the prostate that can spread outside the prostate. And that's what causes the problem with cancer-related death or fatality, is when the cancer cells get outside the prostate, they can cause failure of other organ systems. Prostate cancer is a bit confusing when you get initially diagnosed because there's a wide spectrum of aggressiveness. We tend to have these classifications where we say it's low risk or intermediate risk or high risk. Patients uniformly who are described as intermediate or high risk, we almost always recommend some form of therapy, and that's the second bullet on your screen, and that could be removing the prostate surgery, using radiation techniques to treat the prostate cancer, sometimes hormone therapy in conjunction with other therapies, and sometimes we'll use hormone therapy when the disease has spread, when we haven't been able to cure it with primary therapy. Chemotherapy, of course, is also for advanced disease. In other words, when the disease has spread beyond the prostate. There's immunotherapy, which we'll talk about, and there are a whole host of new and exciting, dramatic advances for advanced prostate cancer. All prostate cancer treatments, just about like everything in medicine, can have side effects, and one shouldn't be overly frightened by that statement. The side effects can be extremely mild, and sometimes they can be pretty major, and we'll talk a little bit more about that. The typical side effects that one may expect if you're doing any kind of therapeutic directed treatment at the prostate is what kind of collateral damage can it cause. So the two organ systems that are right near the prostate are the bladder and the rectum. So regarding the bladder, it can cause a loss of urinary control or urinary frequency. And regarding the rectum, depending upon the therapy chosen, there can be a worsening of bowel control or bowel frequency. It depends on what therapy you're actually having, whether it's a surgical removal or radiation. There's also other therapies to treat prostate cancer besides surgery and radiation, one where we freeze the tissue, and that is approved in the United States by the FDA and by Medicare reimbursement. That's called cryotherapy. Another therapy which is not yet approved but is approved in parts of Europe and in Canada and Mexico is where we heat the prostate tissue, and we call that high intensity focus ultrasound. And there probably will be an application in front of the FDA in the not too distant future to see if we can get that as another option in the United States. But suffice it to say, I just mentioned surgery, radiation, freezing it, heating it, watching it. It can be a daunting decision when one gets the initial diagnosis of prostate cancer. So the fourth bullet, working with your healthcare team, is so important, and it starts with the diagnosis. But tonight's presentation is, once you pick a therapy, how do you manage the side effects, which is very, very important. So you have to be, as the patient and as the caregiver team, very involved in the decision, and also involved in the steps you can take to prevent, or as we say, mitigate those side effects. So it's really important from every stage of the disease, and quite honestly, this is true for all forms of cancer, and it's really kind of true for all forms of any chronic disease, whether it's high blood pressure or high cholesterol. Understand the diagnosis, understand the significance of it. Don't be afraid to ask your physician or your physician extender questions. Knowledge is power. Information is important, and that's very, very key from the start of your diagnosis and throughout all of your care. The urinary health, as a urologist, which is what I am, and I practice here in Myrtle Beach, and I've been here about almost a little over 18 years. Bladder control is obviously very important to all of us, and losing bladder control or getting urinary incontinence is a devastating side effect. It can be experienced after surgical removal of the prostate. Oftentimes as one heals from that surgical removal, whether it was done by a traditional incision, what we call an open, or a robotic, there's always this risk of loss of urinary control with surgery. And there are exercises to do to help improve the condition. We call them pelvic floor muscle exercises or Kegel exercises. Sort of like chicken soup, it can't hurt. It can only help by doing them. That plus time usually helps the situation. But sometimes there can be permanent leakage. And it's not just the surgical option that can cause permanent leakage. We can see this with the other forms of therapy that I mentioned, the cryotherapy and radiation and HIFU. So if the leakage persists, there are a lot of different options that one would want to discuss with your physician, probably your urologist, to help get better urinary control. Sometimes there's just pharmacologic medications. There may be medications to help slow down an irritable or overactive bladder. There may be procedures to inject what we describe as bulking agents to help occlude the urethra to improve resistance. The pelvic floor muscles exercises I mentioned, time in conjunction with that. And then we have a whole list of different types of surgical interventions of using artificial materials to help improve urinary incontinence. And they've changed over the course of time. One of the important things is if you're going to have a surgical intervention to help control your incontinence, you want to make sure that that particular urologist is experienced and seasoned in performing that procedure, especially if they're newer procedures. Radiation therapy historically, maybe 20 years ago, had a high incidence of causing discomfort to voiding or urinating because of its collateral damage effect on the bladder, or what we call radiation cystitis. With the improvements in radiation technology, fortunately, there's been a marked decrease in that complication, but it's still there, and it obviously needs to be discussed beforehand. And the typical symptoms may be urgency and urinary frequency. We can use medications to help these situations. It's pretty darn rare, in my experience, for radiation patients to require surgical intervention for very significant incontinence. Seems to be more common for patients who have the surgical removal. So maintaining good urinary function is obviously very important. Sometimes you can get treated for your prostate cancer and you already have problems urinating, and sort of the ideal scenario is you cure the cancer and improve the urinary symptoms, and we certainly can see that as well. So it's not always the worst case scenarios. Sexual health. Sexual health, if we define that as the ability for a man to have a quality erection, and by quality erection would mean a firmness and a rigidity acceptable to and have enjoyable sexual activity, and typically that for many would suggest intercourse. And this can affect many men regardless of having prostate cancer or not. As we age, we have increased incidence of erectile dysfunction, and that probably is mostly related to blood flow issues, but there are other comorbidities or other health issues such as high blood pressure and diabetes and obesity, high cholesterol, smoking, alcoholism, medications that can make erectile rigidity problematic. After having surgery on the prostate, the nerves of erectile function, as well as having radiation therapy or cryotherapy, they can affect the nerves that supply erectile rigidity, and they can also affect the blood flow. We also see this as a very common effect when we give hormone therapy. Now, we give hormone therapy to lower the testosterone level, and that's typically given in advanced forms of prostate cancer. There are a lot of different indications for it. Sometimes we give it in conjunction with radiation therapy to make the radiation therapy work better. That's called adjuvant therapy. Sometimes we give it if there is a PSA relapse after a primary therapy that has no longer, that appears not to be working. And it's only manifested as not working because the PSA is going up rather than staying low. And then we always give it to patients who have radiographic evidence of spread of the disease, or what we call metastases. Hormone therapy causes a lowering of the testosterone level. It causes a loss of sexual desire, and it makes it pretty darn difficult to have an erection. There are many other effects of the lowering of testosterone, because when you lower the testosterone, you also lower the estrogen levels. And it's profound in terms of its effects on the bone. It causes very significant bone demineralization, just very similar to what women experience when they go through menopause and they get postmenopausal osteoporosis. So we'll talk a little bit more about that. The ways to treat the erectile dysfunction, or the ED, everybody is seeing these ubiquitous, constant commercials on television of the phosphodiesterase inhibitors, Viagra, Levitra, Cialis. They're remarkable in that we never had them until 1998, and they can work very, very well by stimulating blood flow to the erectile tissue. But they're not perfect. They're certainly a first-line therapy for men who have erectile dysfunction. We have other therapies, such as medication that can be injected through a very, very tiny needle into the penis itself on the side. It sounds like it would be gruesome and painful, but actually it's very well tolerated. And these can work well in men who don't do well with the oral medications. We also have vacuum erectile devices, which are approved and covered by most insurances and certainly by Medicare, which use a negative pressure to pull blood flow into the erectile tissue of the penis. And then there's penile implant surgery, which is surgical and is clearly the most invasive and can work extremely well, I think, if all of the other therapies haven't been tried. And if you're the right patient for this, many patients are extremely satisfied with those results. Bowel health, or control of the rectum, you can see problems more so with radiation, because again, that collateral effect, if you're not controlling the radiation right on the prostate and you get too much radiation into the rectum, like the bladder, you can see diarrhea or frequent bowel movements, occasionally bleeding in the rectum. I have to say those side effects have markedly declined in the course of the last few years as we've really become much more sophisticated in our imaging of the prostate and bladder and rectum, so that the radiation is better contained. We really did see a lot of these side effects 15, 20 years ago, but in the last 5 to 10 years the technology has improved dramatically. But nonetheless, these side effects can occur, and if they do, we have usually pharmacologic options to help the urinary frequency as well as the rectal irritation or diarrhea to combat these. And these are usually well treated. Of course, with surgical intervention, one can injure the rectum, and as well as with the freezing procedures or the heat procedures as well. Mental health is something that we've really started to get a better understanding of. I finished my medical school in '84 and my residency in '90, and I can honestly and unfortunately say that we gave minimal attention to this. It was really all sort of lip service. Many organizations now, including the American Urologic Association and the American Society of Clinical Oncology, and the Society of Urologic Oncology, we're recognizing that mental health is so important. There's a great book by Susan Sontag, who's now deceased, but it's Illness as Metaphor. And it really speaks to how we deal with the words like cancer. It's very frightening and very scary. And the physician community is not, certainly we're not ideal at addressing this, but we're doing better. And depression and anxiety are very, very common when one hears this dreaded C word of cancer. And there sometimes is just better communication and counseling which can help patients. And sometimes there's medication, and that's a very individualized decision that one could make with their urologist, their oncologist, or with their family physician or their primary care physician. Fortunately, over the years, we've had a real burgeoning of our support groups. And, one of the nice things about the internet is so many of these online support groups like Cancer Connect. I mean, what an awesome organization that lets you immediately get a hold of somebody and share your concerns, get more education, get more information. And there are many other groups too. You have to find the one that works best for you. And there are many national organizations where you can have in-person meetings as well. I like them all. I think they all are extremely well intended. They're really out there to try to help disseminate information and give support and help folks live their lives successfully and not be overcome by a diagnosis. So the management of the depression, anxiety, from getting a diagnosis, from having complications from treatment, have really improved. And communication is really at the heart of it, because there's no point in living longer if you're not enjoying a good quality of life, you're not able to do the things you want to do, whether it's, run a marathon or just go for a nice walk around the block. We have to cope with our cancer, and you have to make sure if your physician is not giving you what you need, maybe he or she is doing a great job in lowering a blood test or in making sure an x-ray is moving in the right direction, but your overall sense of self has to be first and foremost to living a high quality life. One of the things, just changing gears here, is bone health. For years we had a very poor understanding of bone health and the impact that we caused by starting men on testosterone lowering agents like leuprolide and degarelix. These drugs are great because they put prostate cancer cells in remission. And it was in 1941 that a pioneering urologist named Huggins understood that by lowering testosterone levels in a man with widespread prostate cancer, he was able to put the cancer in remission. So not all widespread cancers are responsible to hormonal manipulation. Breast cancers can be, and certainly prostate cancers can be. But there's no free lunch here, and the hormone therapy not only puts the cancer cells in remission, it has a very negative impact over a period of time on bone strength, bone integrity. So fortunately now we're recognizing that there are many things that we can do to keep our bones strong. Why is it important? Why does it even matter? Well, it matters because when you start this hormone therapy, if you get weakened bones, you run a big increased risk of getting a bone fracture. And a fracture can lead to devastating consequences. A simple fall can lead to a hip fracture and a hip replacement surgery, and there's a high risk of mortality for men. It's actually much worse for men than it is for women. So first and foremost is recognizing if you're at risk, and you have that conversation with your physician. We recently got the approval of a drug. It's an antibody called denosumab. The trade name is Prolia, and it is now approved to be given to men and to women. In men who have prostate cancer, or even who don't have prostate cancer. Any man now who is at risk for having bone demineralization, or what we call osteopenia or osteoporosis, can get this drug. It's given subcutaneously, just underneath the skin, once every 6 months. It's about a little over a cc of drug. It's essentially painless and can be given every 6 months to keep the bone's density stronger. And that's called denosumab. And then Prolia is the trade name. It's 60 milligrams every 6 months. If you have disease in the bones from your prostate cancer, we give a higher dose of the drug same drug, denosumab, but instead of 60 milligrams, we give it 120 milligrams every month. That's called Xgeva, also given just a little subcutaneous injection. And that's for men who have metastases in their bones. Now, in addition to doing the Prolia once every 6 months, if you're at risk for osteoporosis, you supplement that also with taking extra dosages of vitamin D and calcium, and also really have to maintain your exercise pattern, which quite frankly, this is true for aging in general. You know, you have to maintain your chassis. We take our cars all the time to get, maintenance on them. You have to maintain your skeleton. As we age, we naturally lose bone density. As we age, we lose muscle. We have atrophy. So that's why it's important to maintain a regular exercise regimen, not be obese, not be sedentary, not have excess alcohol, wear good-fitting shoes as we get older to avoid tripping and falling, rid your house of a lot of small, annoying rugs and carpets so that you don't end up tripping, and for goodness sakes, don't get up on ladders. Get rid of all the ladders in your house. They keep the orthopedic doctors busy. So bone metastases, that's unfortunately what happens when the cancer spreads outside the prostate, and it's the most common site of spread of the cancer. If we fail to do our job and not cure you with localized treatment, it's the most common area of spread is the bones. Next is the soft tissue and the lymph nodes, and occasionally to organs within the body, such as the lung and the liver. As I mentioned earlier, these bone metastases can cause fractures. They can cause cord compression in the spinal cord, and they can cause pain. Now, it was a great advance that we developed these drugs known as zoledronic acid, the trade name Zometa, and that was approved back around 2002, and then denosumab, Xgeva, in 2011. I was one of the authors of this paper that you see here in the Lancet. First author there was Karim Fazazi of Paris. I'm somewhere in the middle of the pack in that et al. Group. But we're very proud of that. We published and showed that in a head-to-head trial, Xgeva was actually slightly better than Zometa in preventing what we call skeletal-related events, which would be fractures and pain and cord compression and issues and complications of bone metastases. So this really is in the last few years. So we start our patients on these two drugs. Both of them work well. They're covered by Medicare. They're covered by all insurances. And your doctor should absolutely be having the discussion with you if you have bone metastases. Quite frankly, any form of bone metastases outside of prostate cancer as well can prevent complications. So during hormone therapy, we mentioned earlier, when you lower the testosterone level, you lower the estrogen levels too, and that's what causes the bone demineralization, the possibility of osteoporosis and fracture, but it also can cause hot flashes and sweating. For some men, you may get what's called gynecomastia, or breast enlargement or tenderness. You get some weight gain in the central portion of the body. And that can be, depressing and unsettling. So how do you mitigate against that? Well, I'm a big fan of recommending a heart-healthy diet. I like the heart-healthy diet because a heart-healthy diet is a cancer-preventive diet, and you want to understand what your, ideal body mass index is, or the BMI. You want to exercise regularly, you want to avoid obesity, but you also want to avoid being undernourished as well. If you exercise regularly, eat a heart-healthy diet, it'll help you sleep better, which also helps your fatigue, or avoids fatigue. Let's face it, as we all get older, we have less energy. If you throw on top of it, cancer-related therapies, and being out of shape and being overweight, it's just going to make your quality of life worse. So you have to be proactive and fight these things. Memory or cognitive issues is something we're still a bit in the dark ages on. We're learning more about this. I think it's extremely important to maintain physical health. One has to maintain mental health. So how does one do that? Stay engaged, stay intellectually engaged, read, stay spiritually engaged, whatever that form of spiritual therapy is for you. This will help you with your memory issues. This will help you with cognitive impairment. And right now, that seems to be the best we can. There are a lot of over-the-counter products that are positioned out there. I don't recommend any of them. I think right now most of them really fall under the category of snake oil. There are some FDA-approved memory products that are particularly designed for patients who have issues of dementia, and I would not recommend putting anyone on that until they saw a neurologist and had a full evaluation. Chemotherapy. So we had no chemotherapy for prostate cancer until 2004, and it was a big breakthrough. We had that approved, but unfortunately chemotherapy has a lot of side effects, and it can cause lowering of the white blood cell and red blood cell count. We can see loss of hair, known as alopecia. Chemotherapy attacks rapidly dividing cells, and the cells that line the gastrointestinal tract, the stomach and the intestine, are rapidly dividing, just like our hair follicles are rapidly dividing, just like the bone marrow is rapidly dividing cells, and that's why you see these side effects of lowering of white blood count, loss of hair, and diarrhea. And you can see the nerves affected in the arms and in the hands, and you can get some neuropathy or tingling or numbness. Now, the good news is we've become a lot better in treating and managing side effects of chemotherapy. So I don't want anyone to think that just because you're getting chemotherapy, it's a bad deal. It's not. Some of our chemotherapies are extremely well tolerated. We've had some new advances in second-line chemotherapies, and they can really help patients regarding other issues of pain and loss of appetite, and actually improve their energy levels. So don't let the word chemotherapy scare you. When you go and see your medical oncologist or your urologist who's administering it, you just have to be proactive. Many times it's the physician extenders, the nurses, who are so good at counseling on ways to avoid these side effects. So general health and wellness, you know, I mean, heck, this is about how we age gracefully starting really after age 30. It's not just about cancer, it's more amplified. And so you want to make sure you discuss your issues with your team, and the team is not just only the physician, but it's all of the different extenders, whether it's a physician assistant or a nurse or an LPN or a medical assistant. And quite honestly, it's your team at home, you and your significant other or your children or your friends who can help you at your support groups, Cancer Connect, others. I mean, this is how you really make a good game plan. Don't just rely on your physician. You really need to go the extra step. And everyone's different. Some of us need more rest than others. Not everybody requires the same algorithm. Not everyone needs surgery. Not everyone needs radiation. And not everyone needs chemotherapy. You know, the treatment of cancer is not cookbook. You still have to understand and individualize, and you understand and individualize better if you're armed with knowledge. No one can ever tell you to avoid regular physical activity. It's so vitally important for your energy level, for your disposition, your mood. It helps you with all of the therapies that I've mentioned earlier. A healthy diet is high in vegetables and fruits and whole grains, and probably low to moderate in carbohydrates. Again, I'm a big fan of the heart-healthy diet. Go Google and look up any kind of heart-healthy diet is a great cancer diet. And don't waste a lot of money on a lot of over-the-counter products which have never been validated. And unfortunately, we have a multi-billion-dollar over-the-counter industry that preys on false advertising. It makes me sad. You know, some of it may have value. I'm not trying to completely dismiss it, but we have to do better studies to show if indeed high doses of pomegranate juice or cranberry extract is going to really help you. It may indeed, but just be careful where you get these therapies, and don't let that become a panacea for you. Still maintain a good heart-healthy diet and regular exercise. These dietary supplements may be helpful, but many of them are not safe for use. You have to be careful where you're picking them up. As many of you know who are listening, the over-the-counter market is nowhere near as well regulated by the Food and Drug Administration as our prescription drugs. So one has to be very careful where you pick these up and the dosages that you're taking. And that's true for all vitamin therapy as well. So side effects are common. Side effects occur when we age, but side effects can be more daunting when we have cancer and when we've had localized as well as systemic therapies that change our normal hormonal balance, that change our normal bone health, which change our normal weight distribution, our sleep patterns, our sex drive, and our energy patterns. But we can combat these. We have FDA and Medicare and third-party approved therapies to keep us vigorous, to keep us healthy. But your overall health, it's very important to maintain that diet, physical activity, and understand if you're having a side effect, whether it's a gastrointestinal or a skin side effect or a bladder or bowel control side effect, we've got a lot of new therapies that can help you. Make sure you're getting the information from your caregiver, be it the physician or his ancillary or auxiliary team. So I think this is going to give us some time for some questions and answers, and I'm happy to take everybody's questions and answers. We've got a few just to start with, if that's okay, that have already come in. The first one is from Jersey City, New Jersey. I hope who's ever asked that they've recovered nicely from the Sandy storm. I was actually up there for that. That was just devastating. Does age factor, here's the question from Jersey City, does age factor into whether or not you will get erectile dysfunction after surgery for prostate cancer? I think most of us would say yes, it does. You know, as we age, regardless of having any therapy, our erectile function diminishes, for some more than others, and part of it may be overall health and genetics and other contributors, but most of our data suggests that a man who's 50 years old and undergoes the surgical removal of the prostate has a much higher likelihood of maintaining his erectile function than a man 70 years old. Probably has to do with a whole host of things. Sometimes it can just be the surgeon's technique. As we get older, our testosterone levels will lower. As we age, we know that there's diminished blood flow. So the answer is yes. Age can be a prognostic factor for maintaining or worsening erectile function after surgery. Here's another question from New Jersey, Jamesburg, New Jersey. I had a laparoscopic radical prostatectomy 3 years ago, and my erections are about a half to 2/3 as firm as they used to be. Will this ever get better, or is this the best I can expect? Well, most of our data suggests that the erectile function is maximized post-surgery at about 2 years. However, you know, I never like to say that use absolutes like always and never, and it's certainly possible with time, but I think probably the maximum spontaneous return is seen at around 2 years, certainly by 3 years. So for that patient in Jamesburg, I would be looking at augmenting therapies, as we talked about before, whether they're the oral daily pills such as the Viagra, Levitra, Cialis. There are injectable therapies. There are pellets, a little like the size of a rice kernel, called alprostadil. The trade name of that is Muse. And then there are the vacuum erectile devices, and of course there is the penile implant surgery. So, you know, everyone's sexual desires can vary quite significantly depending upon their stage of life, their partner, etc. Be assured that if you are not getting the rigidity you want, there is definitely a therapy to get there. All right, Boston, Massachusetts. Can diet or supplements other than prescription drugs help with sexual problems after treatment? Well, I can tell you that if you look at the AUA guidelines on this and recommendations from the AUA, the American Urologic Association, or the European Urologic Association, they do not recommend any over-the-counter supplements as being better than another. That said, I like to keep my mind open to certain things, and I certainly wouldn't dissuade you from trying. I'm bothered by the hucksters I see on television. Quite frankly, I find it somewhat sad seeing ex-football players getting on there and hawking therapies that are over-the-counter and not well regulated. Oftentimes, these medications have poor quality control. Many of them are bootlegged with existing approved pharmacologic therapies. They have very bad quality control. That said, I'm a believer in that there may be herbal and nutraceutical medications that certainly could. The answer is it's not fully proven yet. So buyer beware. Unfortunately, to me, my bias is that many of these companies are just looking to make a buck, and I'm loath to recommend any of them until there is obvious, well-designed trials and published in peer-reviewed literature showing the efficacy as well as the safety. So, buyer beware, check it out, but be very careful. Los Angeles, California. I have advanced prostate cancer, and I took the treatment Provenge. Provenge is an immunotherapy. It was approved in 2010. We published those results in the New England Journal of Medicine. I'm also proud to be an author of that article. It's the only immunotherapy to date right now approved in advanced solid tumors. Actually, I take it back. Another one was just approved in metastatic advanced melanoma. And that same drug is actually being looked at in prostate cancer. It's not yet approved in prostate cancer yet, but Provenge is approved for men who have advanced prostate cancer. And the question the fellow from Los Angeles has, is there anything after that like new treatments? Oh my gosh, there are so many great new treatments that have been approved since Provenge. Now, Provenge, to me, is foundational and a very important therapy to receive because it's a way of focusing the immune system. Different from hormone therapies, different from chemotherapy. It's given once in the office, takes about an hour to get the treatment in the office. It's given a total of 3 times. It's very well tolerated. There are 2 new oral therapies that have been approved that work on the androgen system. Androgen is another word for testosterone and the metabolites of testosterone. The androgens stimulate a receptor on the prostate cancer cell called the androgen receptor. We've had 2 new oral agents approved in the last year alone, and they're called Zytiga and Xtandi. These are not chemotherapies. These are not immune therapies. These are hormone therapies targeting those receptors in the prostate cancer cell line, which have shown to be very well tolerated, oral daily medication, and have extended life to men with advanced prostate cancer. And I think that these will be, these already are approved for men who've received chemotherapy. They will soon be approved, I'm very optimistic, for men prior to chemotherapy, just like Provenge is. And I don't think you'll take one versus the other. I think you'll be taking all of them. What we don't know yet is the best way to sequence these therapies or combine them. I think we'll find that they will be very well combined and sequenced appropriately. The bottom line is you're going to be taking these therapies before chemotherapy. Why is that important? Because they're better tolerated, and we keep saving our arsenal of treatments for other things. We'll have more arrows in our quiver to use, as is often said, to attack prostate cancer. Bottom line is we're making prostate cancer, advanced prostate cancer, a chronic disease, much like high blood pressure or high cholesterol. Another question from Madison, Wisconsin. With a PSA now rising after initial treatment, my doctor says I can wait before I do anything else. If the cancer is coming back, shouldn't I be doing something now? Does everybody just wait? Well, it's a controversial area. If you've had a localized therapy, surgery, radiation, and your PSA has not gone to undetectable and or it's going up, we don't know when is the best time to start testosterone suppression therapy. It's an individual decision that needs to be made with your doctor based upon the original pathology that you had, how aggressive was your cancer, how important your erectile function is ongoing at the current time, and what is the rate of rise of your PSA. Is it rising very quickly? And one of the things we calculate is known as the PSA doubling time. So it's an individual decision. We don't have the perfect answers. It's a no-brainer to start hormone therapy if you get a bone scan, a CAT scan, or an MRI or a PET scan, and you show that you have radiographic evidence of disease. Indianapolis, Indiana, can you tell me if the band surgery is worth doing? Well, by band surgery, I'm assuming they're talking about an artificial sphincter for urinary incontinence. Certainly not talking about the band surgery for obesity. That would be a whole nother conversation and talk. That's pretty popular these days for morbid obesity. But for urinary incontinence, I'll assume that's the question. The answer is yeah. If you've tried conservative measures and you're going through multiple pads a day and it's impacting your quality of life, and you've given time to get over your primary therapy, and you've tried pharmacologic therapy if appropriate, and you've looked at conservative treatments, there are now several new techniques to help male incontinence. My recommendation is make sure you go to someone who's familiar with the technique and has had experience doing it. Wilmington, North Carolina, just up the road here from Myrtle Beach, where we're talking to you tonight from. Do bisphosphonates reduce the risk of cancer metastases? Thought I read something about this in a book by Dr. Agus, but not sure if this is true. Well, I apologize. I don't know who Dr. Agus is. The answer is that bisphosphonates have not been shown in any large phase 3 trial to reduce the risk of developing bone metastases. Denosumab, also known as Xgeva, actually has shown to delay the risk of bone metastasis in men who have advanced prostate cancer who don't have bone metastases. And we published this in The Lancet. I'm one of the authors. We actually went to the FDA, and it's the only drug to date in a large multinational trial that actually showed a statistically significant improvement. The FDA felt that it wasn't clinically significant enough, and so the sponsor of the study. So right now, it's a real unmet need in the area of prostate cancer. We don't have any approved therapies yet for preventing the onset of bone metastases. We've had many other studies and trials that have failed. Denosumab worked, but it was not felt to be of clinical enough significance yet by the FDA. Personally, I disagreed with that. I actually testified there, but that is what it is, and that is public record. Sarasota, Florida, I have been on Xgeva, which is 120 milligram denosumab every month since May. My most recent PET bone scan showed where a crack in the pelvic area was healing. How long will I be able to take this drug? Well, Xgeva monthly is prescribed for men or women who have bone metastases from solid tumors, period. And the answer is we recommend taking it indefinitely, assuming you're not having any complications from the medication. there is a percentage of patients who can get some complications, and it usually is an ulcerative condition in the gum line, and that has to be monitored carefully, but it affects about 1 to 2% of patients annually. It has a much more dramatic effect in preventing those skeletal-related event complications of pain and fracture and cord compression. So the answer is, if you have bone metastasis, it's theoretically to be given in perpetuity, but like everything else, one does need to individualize. So here's another question. Hormone therapy has a tendency to atrophy one's genitalia. Is a penile pump a suitable method of exercising to maintain blood flow? I think it's certainly very reasonable. Your surgery and radiation can sometimes cause atrophy of the phallus or the male genital. Hormone therapy certainly can make that worse. I think the vacuum erectile devices or the penile pumps is a reasonable strategy. Some have also felt that adding regular use of the PD-5 inhibitors, the Viagras, levetiracialises, can also help. Next question: why can't prostate cancer that has metastasized to the bones be cured? Well, wow, what a great question. We certainly would like to cure it. We just don't have the therapies available to cure it, whether it's hormone therapy or immune therapy or chemotherapy. We are unable to cure it. I wish we could. I'm certainly hopeful in my career and in my lifetime. What we want to do is make it a permanent state of remission, and don't want any of our patients to die of prostate cancer. I frequently say in lectures, we want everybody to die of old age, right? And old age is just a kind of a euphemism for a cardiovascular event, right? That's what we used to say when we were kids. You died of old age. Old age is a heart attack or a stroke. And we're not going to live forever, but we don't want to die of cancer, which seems to be caused by either environmental issues or a genetic predisposition. So that's our goal. Is surgery an option after radiation fails? It can be. Surgery can be an option after radiation failure. There are some pretty risky complications from it. There are other options in addition to surgery if radiation fails. Some people will recommend more radiation, and some people will also recommend the use of freezing the tissue called cryoablation, and also now high-intensity focused ultrasound, or HIFU. That's one of the trials that are on the verge of completion and in front of the FDA. So if there's no cancer outside the prostate, one can certainly look at other second-line therapies to try to affect a cure. Can medical science suggest any way in which the nerve bundle affecting erections can be repaired after a radical prostatectomy? Well, we've tried a lot of different things along the way. There have been interposition nerve grafts, and some medications have been looked at to try and improve and prevent nerve damage. We haven't met with too much success with those. I think the key thing with surgery is a very savvy and technically skilled surgeon who can try and avoid damage to the nerves in the first place. Have you heard of palpitations, specifically a flip-flop feeling of the heart as a side effect of either, I'm looking over here, I'm assuming of either of the therapies? Have not seen a lot of side effects with the localized therapies. I'm assuming the question is really geared towards the systemic therapies. Fortunately, have not heard a lot of heart palpitations with the hormone therapies, but the FDA has issued a warning that you can sometimes see some changes in the heart rate with a lowering of the testosterone. It's controversial. right now. There have been several large studies that have looked at this issue. Do the hormone-lowering therapies cause an increased risk of cardiovascular events? There have been studies which suggest that it might, and studies which suggest that it does not. I think it's important to recognize that most of our men who are receiving hormone therapy are older, and they do have other comorbidities. So whether that's high blood pressure, high cholesterol, obesity, one needs to be cognizant of that and keep that in the mindset that you're adding any new therapy, that we don't want to make the cardiovascular risk worse than it is. So if you're going to pick a therapy, make sure that it's ideal to pick that therapy and not just do it as a reflexive strategy. Well, I think we've reached the end here at the hour limit. I hope my discussion was clear. I wish everybody on the audience listening in a wonderful holiday season. If I can leave you with one take-home message is, number one, the side effects of localized prostate cancer and advanced prostate cancer, our understanding has improved dramatically. And we have ways to mitigate against those side effects. And if you're not getting answers, you can get them at Cancer Connect. You can get them through your physician. You can get them on the internet. Talk to or other organizations. And the second message, and probably even more important, is I firmly believe within the next few years we are going to be, we are already seeing this now. We're making advanced cancer a chronic disease. And advanced prostate cancer is the second leading cause of death in the United States of all advanced cancers after lung. And that's really our goal. We don't want anybody to die of prostate cancer. That's the 30,000 men who do die, unfortunately, annually. And we're making great strides in that. So it's a great time to be optimistic during this upcoming holiday season. Thank you very much for listening.